Good day to everyone joining us and welcome to today's XTalks webinar. Today's talk is entitled Fecal Matters, Clinical Impact and Cost Effectiveness of Molecular GI Pathogen Testing. My name is Sarah and I'll be your XTalks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. This webinar is designed to be interactive and webinars work best when you're involved, so please feel free to submit your questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, please contact me by sending a message using this chat panel. At this time, all participants are in listen-only mode. Please note that this event will be recorded and made available for future download. Live audience members can apply to receive a professional acknowledgement for continuing education, or PACE credit, issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. Certificates for approved applications will be emailed by July 22nd. At this point, I'd like to thank Nanosphere, who helped develop the content for this presentation. Nanosphere is dedicated to enhancing medicine by providing targeted and flexible molecular diagnostics that can lead to earlier disease detection, optimal patient treatment, and improved healthcare economics. Their platform, the VeriGene system, enables clinicians to rapidly identify the bacteria and viruses responsible for some of the most complex, costly, and deadly infectious diseases. Currently, the VeriGene test menu targets infections of the bloodstream, respiratory tract, and gastrointestinal tract. Now I'd like to introduce our speakers for today's event. Dr. Harrington is currently the director of the Clinical Microbiology Laboratory for the University of Illinois Hospital and Health Sciences System in Chicago, Illinois. Dr. Harrington received her PhD in microbiology from the University of Kansas in 2005 and completed a postdoctoral training program in medical and public health laboratory microbiology at the University of Washington. Dr. Harrington's research interests include bacterial strain typing and molecular epidemiology, rapid diagnostic and molecular-based testing in clinical microbiology and infectious diseases, and metrics-based assessment of quality in clinical microbiology. Dr. Alexander graduated as a physician from the Central University of Venezuela with post-training in medical and public health microbiology. Dr. Alexander's work has been specialized in antimicrobial susceptibility testing, detection of antimicrobial resistance through phenotypical and molecular tests, and antimicrobial stewardship programs. Currently, Dr. Alexander is coordinating and directing the Microbiology Department at the Marin General Hospital, integrating rapid molecular tests and multiplex panels. So without further ado, I'd like to hand the presentation over to our first speaker, Dr. Harrington, and you may start your presentation whenever you're ready.
Okay, well, thank you for that kind introduction. I'd like to thank Nanosphere for inviting me to speak here today about our experience. I'm going to talk about some of our experience and initial outcomes with the implementation of the Enteric Pathogens panel. And one thing I think it's important to keep in mind is that when you're thinking about implementing or integrating a panel-based test like this, that one size doesn't always fit all. So it's important to know a little bit about who we are to see maybe how we might compare with your system as well. So University of Illinois Hospital and Health Sciences System is a large integrated system centered around an urban academic medical center here in Chicago. We're affiliated with University of Illinois, so that's our Illinois at Chicago, that's our academic affiliation. And then in addition to our acute care hospital, we are also integrated with a network of outpatient clinics and a federally qualified health center network throughout the city of Chicago. We're also a teaching hospital. We're the largest medical school in the country with over 2,000 medical students and residents each year. And in addition, we also have an outreach service where we act as a laboratory, a reference laboratory for other community hospitals and centers here in Illinois and throughout. Our laboratory is a medium to large size laboratory. We have a 24/7 operation staffed specifically by microbiologists. And although we do about 300,000 tests annually, a third of that is bacteriology. So our bacteriology service is concentrated on the day shift. And prior to implementation of our molecular-based panel, we were doing stool culture 7 days a week. And about a third of that was coming from our inpatient acute care population, 40% from our outpatient, so our clinic networks, and then a quarter of that coming from reference laboratories. So quite a diverse selection of specimens coming from different locations. And so that was something we took into consideration with the panel, adoption of our panel. Here's just a look at our stool culture positivity rate over the last few years. We stay pretty consistently around 4.5% as we've gone over the data from the last 5 years. And this is the distribution of the organisms that we see from our positive stool cultures. So as you'll notice, our data mirror largely what we find in national studies. We recover a lot of Salmonella and Campylobacter, but in our institution we also screen for Aeromonas, and we do find a significant amount of Aeromonas from our patient specimens. So when we were considering looking at a molecular testing platform, we looked at it from a bunch of different angles. And if your laboratory is like ours, one of the most significant impacts we've had lately is reduction in staffing. We just don't bring on new staff as quickly as staff leave, and this is one of the challenges to the clinical microbiology lab. So we're being asked to do more with less, and so we're looking for ways that we can do that, and molecular testing, because it's quick, is a good way to do that. We really wanted to optimize our workflow. If a significant proportion of our cultures were negative, can we find a way to get those negative cultures through our system faster? And then, of course, we're looking for, always looking for how to improve patient care. So molecular panels offer the option to bring in testing that we currently weren't offering, for example, Shiga toxin testing. We can turn the results out significantly faster than we could with a culture-based workup. There's been a demonstrated improvement in sensitivity for these molecular panels in several targets. And one specific thing we were definitely looking for was a mechanism for rapid detection of norovirus, especially within our hospital setting. So those were some of the considerations we took into looking for a molecular panel. And so let's just talk a little bit about the significance of norovirus and rapid detection of norovirus. So norovirus is the most common cause of foodborne illness in the United States, and it's a significantly large chunk of what we see. The impact when you have a case of norovirus in the hospital can be really significant. So a case of norovirus spreading within the hospital leads to loss of revenue, not just the cleaning costs, but if this spreads within your staff, people are out, sick time, etc. So the impact can be really significant in a hospital setting or other type inpatient setting. But in comparison to norovirus, which causes the most of our foodborne diseases, we're looking at something like Salmonella. So some really interesting data came out from the USDA, and they did some economic research looking at the economic burden of these targets. And while norovirus is the most common cause, Salmonella turns out to be the largest percentage of economic burden. So more patients infected with Salmonella are hospitalized. There's a higher rate of mortality. And so they looked at just 5 pathogens causing 90% of the economic burden in terms of care, patient death, and what goes into the public health system in terms of prevention of these infection with these types of pathogens. And just a little bit of breakdown for Salmonella, they estimated just over 1 million cases in the United States of foodborne illness related to Salmonella, and these are non-typhoidal strains. Only 2% of those patients end up being hospitalized, and of those, only 2% die. However, it's almost 90% of the impact, economic impact, from those very few cases. So the impact to not only your hospital system, but also the public health system can be significant. So those are things to take into consideration as well as we move forward with trying to improve patient care. So why did we select Veregene? I wanted to just briefly go over some of the things that we took into consideration. So there are 4 FDA-approved panels out on the market now to choose from. Different platforms, different targets on each of the test menus, as you can see here. For us, we had 2 platforms currently in our laboratory when we started to evaluate testing. So we wanted to try to keep it limited to those 2 platforms. And we also wanted to pick a test menu that was a good fit for our population. So we looked to see what kind of organisms or targets we were detecting in our patient population and looked at what platforms were available. We were looking specifically for something that included norovirus for the reasons that I've just talked about previously. And then in addition, we felt like inclusion of C. difficile on the panel was maybe possibly a negative. It's potentially confusing to clinicians. We also had an individual single target test available already for C. difficile, so that was a confounder for us. And in our patient population, we have very limited positivity for parasites, including Cryptosporidium and Giardia. And then we also looked pretty hard at the cost of the lab reagents. That's one thing that our administration is continually asking us to scrutinize the actual cost of the reagents, independent of the reimbursement argument. So this is a breakdown of the stool culture workup and tests in our system. You can see the cost listed here. And for norovirus, we were sending out about 5 of those a year. So, so when we looked at this, just based on cost, it's really an apples and oranges argument. And Shiga toxin for us is not a test that we were offering, and it was only being performed or sent out requested in rare cases. But one thing that we did look at and talk about, and it's very hard to quantify in numbers, but there are a lot of things that aren't accounted for when we go into our cost analysis. So for example, with stool culture, are we accounting for the time it takes to walk over to the other incubator for the Campylobacter jar and to go get the indicator from the refrigerator? And I think a lot of those inefficiencies in foot traffic often don't get accounted for in our cost analysis here. So I think stool culture is probably a little more expensive than we were estimating. So in terms of our evaluation and validation plan, we used both leftover stool samples from clinical culture and control material from a Zeptometrics panel. We wanted to run a significant amount of stool samples that were negative by culture to see if we could pick up pathogens that maybe we hadn't gotten by culture. And we also tested some samples that were positive by culture as well. And then ran the nucleic acid control material for targets, especially things that we knew we wouldn't have in our laboratory, like Shiga toxin, and we didn't have a Yersinia strain to test as well. So this is data from our verification summary, and you can see the distribution of the targets here. We had really good concordance. We had 4 discrepant samples where organisms were not viable on recovery. Those were Salmonella and 2 were Shigella. And I think these results were really expected. We didn't have an enrichment process in place for helping recover these organisms. And we know that Shigella are labile in transport and often die. So I think these are pretty explainable discrepants. So in our hands, this test turned out to be more sensitive than our culture-based method. And then we found our internal control failure rate was about 5%. And so that's been consistent with what's been reported by the manufacturer and other laboratories in this small evaluation. So in addition to that, what other kinds of diagnostic considerations and operational implementation did we look at? One of those was Ehrmonis. What should we do about Ehrmonis? It was something our lab had been looking for and reporting previously, and we felt like based on our distribution, we wanted to continue that. There's a really nice review out there, ClinMicro Reviews, talking about the clinical significance of Ehrmonis and gastroenteritis, and I don't think there's been a definitive interpretation as to whether these are true pathogens or not. But like I said, because we could see a significant proportion of Aeromonas previously reported, we felt like that was something we wanted to continue. So we implemented an Aeromonas screen, or continued an Aeromonas screen, which is what we had been doing as part of our standard stool culture workup. We set this up now when our stool is received, and we just use a blood agar plate like we were before, and screen that blood agar plate using a sweep oxidase test. So just take your swab and then drop a little oxidase reaction on there to see if we get a positive reaction, and also look for beta hemolysis. If that's negative, we'll result that screen, Aeromonas screen, in our molecular panel. So we built that in as a target to report, a reportable target. But if not, we'll reflex, if it's positive, we'll reflex that over to culture to try to recover that for a definitive identification. So this is a fast and inexpensive way to screen for Aeromonas. Essentially, it's what we were doing before in our standard stool culture workup, so we kept that part of the screen. We implemented this test on our day shift Monday through Friday. We've been running this test about 6 months now, and so we're hoping to expand that implementation to evenings and weekends as our staff being trained on this as well. And we put the system in our core microbiology processing area, except for the culture-based testing, which goes to the benches, but it's run in that rapid testing mode in our processing area. And then we do add comments into the reports for positive detection targets that are detected. And here's one example. If we detect Shiga toxin, we add the comment saying that antibiotic treatment is not recommended. So one consideration about placement of this instrument is to think about the fact that our processing areas in microbiology are evolving from this area of processing and accessioning to a rapid testing diagnostic laboratory where we're doing more in this fast-paced environment. So for example, think about something like norovirus, which can have anywhere from 10 to the 4th to 10 to the 10th copies of virus per gram of fecal material. And so that puts us at risk for contamination with any molecular-based platform. And so something to consider when you're putting these tests, these platforms in those rapid diagnostic areas, is to think about contamination control. And so we've definitely decided to use dedicated consumables, including pipetters and pipettes. It's just important to remember never to borrow the pipetter, and that's really easier to say than to do. When you've got a pipetter laying on a counter next to an instrument, it's very easy to transfer that to another location. Utilization of aerosol-resistant pipettes and using good pipetting technique, and to remind technologists how easy it is to contaminate surfaces and work areas and these instruments that are potentially susceptible to contamination, either from template or amplicon-based nucleic acids. And then as probably one of the most important points and easiest to do is to change your gloves. And so, you know, I'm from Chicago. We say here in Chicago, vote early and vote often. And I think of this with our gloves as well. Change them early and change them often. And then in addition to laboratory implementation, we also had to consider our institutional implementation. So what was our specimen rejection strategy going to be? Some of these specimens are coming into us from off-site or from clinics, and what were we going to do with our specimens? Maybe that got to us and they weren't in Carrie Blair as we move forward, and then effectively communicate the change in this testing, because in this case, for our institution, we were accepting or requiring Carrie Blair as the only collection transport container, and so that was a change for our hospital, et cetera, and I'll explain that in just a minute. And so getting this information to who is actually collecting the specimen. So what we had made some other changes in a similar time frame, and so we created this stool specimen collection guide to distribute out to our clients and our providers in our hospital, because at the same time we were doing this, we were also transitioning our ova and parasite exam to a reference laboratory. So prior to the implementation of this testing and some of these changes, from our hospital, we had been willing to accept fresh stool put that into a preservative container if we had gotten that in the appropriate period of time. But now, because we had multiple containers in the mix, we were really trying to be consistent about asking for the right container up front, just to guarantee the integrity of the test. And so we devised this guide, including things like we want diarrheal stool to take the shape of the container, how much we want, and the turnaround time. And so getting this into the hands of especially the nursing staff was a significant portion of the success of getting this test online. So that's a piece that I think needs to be really carefully considered. And then we did have a washout period. We knew there were containers out there and there were people that didn't get the message. And so we did keep our stool culture running in parallel during the implementation of this test for a period of time, just to make sure that our patients were taken care of. So in addition to that, one other thing I think it's important to consider for implementations of this test are the public health considerations and what is required of your laboratory in terms of public health reporting. So Illinois Department of Public Health has put out guidance previously about this, and then just released some updated versions of that just a couple weeks ago in terms of submitting specimens and isolates for public health reporting, and guiding that they would like the isolates if you can recover them, but if not, then they're willing to receive the specimen from these patients. So they're looking for reporting for Salmonella, Shigella, and E. coli 0157 and other Shiga toxin-carrying E. coli. And then occasionally bacteria from outbreaks, specifically Campylobacter. So new to us in Illinois this year is Campylobacter is now reportable to state public health, but they will be asking for the isolates in the incident of an outbreak. So we're utilizing culture in a couple of ways. Like I mentioned, our Airmona screen, so screening for pathogens not detected in the panel. And we are attempting to recover Salmonella and Shigella for confirmation and typing by public health because that's significant for reporting, and then also susceptibility testing upon request by clinicians. But we're not keeping specialized media in-house, and we're not keeping media and consumables for the recovery of Campylobacter. So we really did discontinue that part of the testing. So our post-implementation results, just in the last 6 months, we've seen a pretty significant increase in our positivity rate from after implementation of EP. And this is what our distribution looks like. A significant proportion of our positivity has been due to detection of norovirus, like we might expect. So that's been really interesting. So I just wanted to talk about a couple of the cases that we've come across since we've implemented this test. The first case was an 18-month-old boy who had multiple episodes of diarrhea and vomiting and had come to our emergency department and pediatric clinics, was diagnosed with viral gastroenteritis, and sent home on supportive therapy. He'd been seen 3 times prior to the implementation of EP with no etiologic agent identified. And a week after we implemented this test, we got another stool specimen from this boy and detected Shiga toxin by our panel. So that was something that we hadn't been able to do before, and literally within a week had this case. And then what was great was that we could follow up clinically, and they had put clear instructions in the chart to avoid antibiotics in this case. So not only did they have an idea of what was going on with this patient, could provide proper guidance on care. The second case, or 2 cases, I suppose, were 2 concurrent cases of norovirus detected on the same floor of the hospital. So that's always sending up red flags. Infection prevention got involved quickly and could verify the containment, so the contact precautions of the patient, and also could look at the cases in real time. So these cases were independent of each other, and there was no further spread in the hospital. And so this didn't turn out to be any kind of incident in our hospital, but it had the potential to be. So that was a great success. And just another way to look at cost is to look at norovirus by PCR. So just within the last 6 months, we've had about 30 cases of norovirus. And just saying, you know, if we were the most accurate predictors of who might have norovirus, and we sent out, you know, 1 of 2 positives, even a 50% positivity rate, just looking at the cost, what that would have cost us to get those answers by sending this test to a reference lab is significant. So that's another way to look at cost. What are you gaining? So the reimbursement argument, the reimbursement case in our system isn't always the most convincing strategy for us with administration. The reimbursement models vary by patient population and location, et cetera, and so they really want us to look at costs. And so knowing that we're saving not only sending this to a reference lab, but we no longer have to run the rotavirus antigen test, meaning we no longer have to do the QC and the maintenance and the training. These are also cost factors that are harder to measure, but go into what it actually costs to run these tests in your hospital. And then what we saw from our verification data is that we had missed 2 cases of salmonella by culture. And so the unknown costs to our healthcare system are also potentially significant. So from our point of view, summary and take-home points were that costs can be approached from more than one direction, looking at avoidance of costs or what you gain by efficiency. I think Stool Culture on our stool bench was taking, roughly half an hour to an hour a day, and now that hour can be converted over to something else that a technologist can do. So that's time bought back when we're running this test and resulting it and finalizing it on the same day. I think implementation strategies require careful consideration of individual resources and patient populations. The largest panel might not be, the most comprehensive panel might not be the best fit for your patient population, although it might be depending on what your positivity rate looks like. And implementation strategies, where you're going to place your instrument in your hospital or in your laboratory, I think take some careful consideration. We know that we've had to discuss molecular contamination control, and this is something we need to revisit on a quite frequent basis just to maintain the integrity of these tests. So that's something we've been talking about. And also it's important to check with your public health lab regarding reporting and submission considerations. So we want to look larger than just our system out at the public health at large. And so that's the end of my presentation. Now I'm going to pass the presentation to Dr. Alexander for his part. Thank you.
Thank you, Dr. Harrington, for really good presentation. I want to thank Nanosphere for the opportunity to share this information that we've been collecting for the past year and a half. To start, I just want to give you just a briefly information about our facility. This is the Marine General Hospital. It's a 235-bed community hospital located in the San Francisco Bay Area. And you can see we have the basic medical and surgical services. Also, we serve a population of outpatient, including some of another hospital that is called Canfield Rehab Hospital. It's a long-term facility, and we also work with outpatient and medical groups. Our microbiology department is a very small department. We perform only bacteriology and molecular tests. 60% of our menu is dedicated to molecular testing. We have 6 clinical lab scientists, also known as medical technologists, and we have 1 lab technician assisting the work of the scientists. Our department works Monday to Friday, 6 a.m. to 9 p.m., and weekends 6 a.m. to 4 p.m. Night shift is covered by the core lab scientists that only perform rapid tests. To give you an idea of how big we are, handle all the samples that we receive in the microbiology department, we have a volume for 2015 of 56,000 for outpatient and 29,000 samples for inpatient. In the same year, that is distributed from 56% coming from outpatient from stool sample, 32% from inpatient, and 12% for the emergency department. We have a total annual of 1,350. That is around probably 110, 120 per month. We turning our department, including more molecular testing. I think this is a good time to oversee and evaluate the microbiology department and see what kind of tests can be moved to molecular platform. And how you can see in the slide, we have in the Virgin platform, we have right now 4 different panels: the Enteric Pathogens panel, the respiratory panel, and the blood culture panel that we include gram-positive, gram-negative. We also have the Gene Expert with 8 or 9 different tests, and the Illumigen, where we perform the pertussis. We know that California right now have an outbreak of pertussis. But do we need to switch from stool culture to PCR? So this was the question that we made ourselves in December 2014. So the idea was evaluate what the stool culture is able to give us. So the stool culture are technically challenging. Everybody working on the stool bench knows that. Are they really reliable? Are we really identifying all that we're looking for? And I want to show you that some slides further, and you can see how we've been learning, and that changed the perspective that we used to have from the stool sample. It's time consuming, or turnaround time was around 5 days. The culture depends on organism viability. This is very important for Shigella. And the organism susceptibility is not routinely required. I think those was key for us to move from a culture based technique to molecular testing. Also, if we move to the PCR, we're going to be able to redistribute the benches. Also, we can hire per diem scientists and reduce the FTE. We can improve our turnaround time. The expected turnaround time for that time when we was evaluating the bring this platform in-house was go from 5 days to only 24 hours. We can increase the sensitivity, and we saw that. And we also can bring the viral detection. As Dr. Harrington mentioned before, norovirus is very important. And for us, we have to send our specimen out with a turnaround time to 3 or 4 days. That was a case that also increased the need for this kind of testing. Also, we can have more room in the ambient incubator. We can reduce the purchase of special media, and we can screen for Vibrio and Yersinia routinely. When we used to perform stool culture, the physician had to have high suspicions of Vibrio of Yersinia. So in that case, we add the special media. But now we are able to do routinely. Also, we are able to screen for Shiga toxin genes instead only the superficial antigen and also the producing of toxin. And this test is able to detect only the genes, and we also are able to look for non-0157 and non-toxin producing Shiga toxin producing E. coli. These were the 2 platforms that we went through when we trying to make our case. The Virgin, and in this case, one of the reasons was because we had a platform in-house. So this is the 2 panels for the BioFire, the Virgin. I just highlighting the Clostridium difficile is in the BioFire, and also there is 4 parasites in that panel. And those are very interesting. Being able to identify parasite by PCR instead of the whole trichrome, all the technique that is used right now for parasite, that can allow some small hospital, like community hospital like us, to be able to perform parasite in-house in the future when the PCR panel is completely integrated. But the C. diff and also those parasites was one of the reasons that we consider move to the Virgin. I want to explain that in other slides. So the Virgin platform was already in-house. We had 3 processors and 1 reader. So we started using the Virgin 1 year previous to the Enteric Pathogen panel when we validated blood cultures. We also are able to separate targets individually or create sub-panels, and this was important. We are able to order only norovirus or rotavirus, and also we have a bacterial panel that included 2 Shiga toxin genes. From the 2, we have also a viral panel that includes rotavirus and norovirus. What about the Pseudomonas and Plesiomonas? And do we need a parasite panel? So this is the instrument that we have in-house, 3 processors and 1 reader. It's running practically 24/7. So before to move to decide which panel which platform we want to be using, I went to review stool culture for the previous 2 years, 2013 and 2014. And what I found was only 3% of the stool culture were positive for an enteric pathogen. 110 stool culture per month. The turnaround time was only 5 days, but up to 20% of the culture were held for more than 5 days, with an average of 7 days. And the reason of that is when you have a stool culture and you have a non-lactofermenter or some colony looks suspicious, you have to continue and do is isolate and use other special media, sometimes even perform some identification testing to find out that it's not an enteric pathogen. So, and this is a very important situation too that normally we don't consider it when we evaluate the whole stool panel. We only have one Aeromonas isolate in February 2013. Different than Dr. Harrington, Aeromonas in our facility haven't been a problem at all. Probably we've seen Aeromonas 1 or 2 per year on superficial ones, but not from stool samples. And we haven't had any Pleishiomonas. I know those two organisms sometimes are common questions about when we want to move from stool culture to PCR. Ovum parasite. In 2014, we performed 90. We send out 90 samples per month to perform ovum parasite. 98% went from outpatient. But the important thing here was less than 0.1% were positive. We're talking about all of them practically being negative. So parasite testing criteria are not the same for bacterial and viral infection. And I think if we include a parasite panel along with the bacterial and viral panel, some patient can be, we've been testing patients for organisms that the prevalence are not enough. Those are kind of testing we recommend to be able to screen for them when other options have been already ruled out. There is no full parasite panel available right now, so any PCR testing, any PCR-based test that we can use for O1P required to be reflex to the regular trichome to screen for other parasites. So why the Virgin? The platform we're already in-house, able to customize individual target or create sub-panels, CDF not included in the panel. I think this is important because the criteria for CDF are different for the other bacterial infection, especially in a healthcare setting. And no parasite panel was needed in that time. So how did we validate the EP panel? The validation protocol, we went through a different source for samples. We used 10 known positive and 10 known negative samples from the Department of Public Health. We communicate with them and they give us some samples. Those are from previous patients. We used 10 known positive samples that we frozen incredibly from previous years. And we also used 10 QC samples. In total, we used 40, 30 positive and 10 negative. But we need to evaluate the panel as the panel have 9 different targets. And so that is the way that we did the validation. So we also run 5 positive samples by the same operator and 5 positive sample by a different operator. So we calculate reproducibility and precision. So this is what we knew before to do the validation protocol, to perform the validation protocol. We have 30 known positive samples, 62 positive targets. Some of them have multiple organisms, some of them have only one. So, and this was the distribution. We use 9 Salmonella, 8 Shigella, 11 Campylobacter. We also had the opportunity to have 6 Yersinia enterocoliticas. Most of them came from the QC. And we also use 6 Shigatoxin 1 and 3 Shigatoxin 2. And this was the result. We knew that we have 62 positive targets, and the Virgin was able to detect 61. We also knew that we have 298 negative targets, and all of them were ruled out by the Virgin. So in total, we have a sensitivity of 98% and specificity, reproducibility, and precision 100%. We missed one Salmonella. This wasn't detected or recovered from the culture. This was from culture that we frozen from 2 previous patients. What we thought is probably the whole specimen and the organism was compromised. So how did we implement it? So we created 4 different orders, and those orders was divided, and the physician will be able to order the specific sub-panel or target that he wants. So we create a stool PCR panel, it's only bacterial panel, also included 2 Shigatoxin. We create a viral enteric pathogen PCR that is a viral panel that includes rotavirus and norovirus, and we also are able to order a separate the viral. One of the viruses just as an individual target. The operators are responsible for setting up the instrument for a specific target or panel. The customized stool culture for Aeromonas. We also create a customized stool culture for Aeromonas, Plesiomonas, Pseudomonas, and Staph aureus. We also, in this customized culture, we are able to include other organisms, but this is only by request. When we start performing stool by PCR, we stop doing culture at all, and I want to explain that later. We also have a yeast culture and VRE screening culture, both of them only by request. And this is important because in 2 years, we only have one request for one physician for the same patient that require both, 3 of them. The customized stool culture, the yeast culture, and the VRE screening. All of them were negative. How we distribute the benches? Well, before the PCR, we have 2 day shift scientists coming at 6:30 a.m. and we have one coming at 11. The one coming at 11 stay until 9. So each scientist was assigned one of the benches. The evening scientists have the stool bench. We also have a CLT working Wednesday through Friday. So after the PCR was implemented, the benches during the weekday changed. We only have now only 2 scientists working in 2 benches. Respiratory was moved to the blood and miscellaneous, and genital to urine. Now we have also a clinical lab technician working from Monday to Friday, assisting the scientists. But now we also have per diems working only 5 hours Monday to Friday, performing routine, gram stain, stat tests. The weekend was the same. The only difference is that scientists coming at 11 a.m. now was coming earlier because we don't have a PM person in microbiology in the time. And the CLT was working only Saturday. After the PCR was implemented, we were able to move to only 2 scientists. So overall, 3 benches were redistributed and reduced to only 2. 95 hours of scientist time were saved every 2 weeks. So we're talking about a little more than a whole full-time person. We improved the turnaround time from 5 days to 6 hours. That's our current turnaround time. We increased the sensitivity of the detection of enteric pathogens from 41 organisms in 2014, that was a prevalence of 3%, to 2015 to 101, that is 8% of positive rate. The cause. Cause is a little bit complicated to consider, but in this case, we can just collecting some data. We found that around 20 to 21%, $20 to $21 was the cost of stool culture, the basic stool culture. If we need to isolate or continue working screening some of the organisms that we isolate, we found out that that could add a cost of around $4, depending on what kind of media or identification method we use. The operator time per culture, the processor, the setup time was around about 5 minutes per culture. The CLS, the microbiologist working on the bench, working on each culture for 5 days, so it was an approximate of 30 minutes per culture during the 5 days. But now with the PCR, the cost is $64 per the cartridge. The processor are not involved. The specimen is brought directly to the microbiology department. This is one important, interesting thing. The people doing the processing, all the technician or the lab assistant processing stool, they really will appreciate the change. And the microbiologist working on the bench now, that we don't have bench anymore, but the hands-on time for the setting up the whole test is less than 5 minutes. Involving the public health department is really important. We work with the Napa Solano Yolo Marine Public Health Lab. We communicate with them when we want to switch from the culture to PCR. But we work very close to them in the way that we now process the positive result. Positive samples, Salmonella, Shigella, Vibrio, Yersinia, and Zika toxin 1 and 2 are sent to the public health lab. We used to isolate the organisms, trying to isolate the organism and send the isolate to them. But that was a little complicated. We still having all the plates in-house in case that we couldn't identify the organism. So we get an agreement with them, and now we send a specimen, and they are able to identify, they isolate and identify the organism. And we got, after that, we get a more comprehensive identification. Example, like Zika toxin, this is 157 All the positive results are reported to the California Department of Public Health. We have an electronic transmission process, and susceptibility is only performed by provider request. So if we have a physician requiring susceptibility, we call the Public Health Department, and they are able to perform this test for us. So what did we learn and improve during this time? I think in all this information that you can see in this graph, 2014, the blue bars, and 2015, the yellow one, Campylobacter is the most impressive one. We went up from 14 to 55 organisms. The rest of them keep kind of the same, but this was really interesting. And we know Campylobacter requires special media and also conditions that could be impact on the Campylobacter result. But this one was the most interesting one from all information that we can collect from the PCR. Working, detecting, and identifying Shiga toxin. So you can here we can compare when the Shiga toxin, the Shiga gene from toxin 1, toxin 2, and toxin 1 and 2, the color blue, yellow, and gray, and how they compare with the result from the Public Health Department. 16 Shiga toxins were detected during 2015. But the interesting thing is 6 of them were doesn't have any superficial antigen. All the Shiga toxin 1 were O26. And I just want to mention the case that Dr. Harrington just mentioned before, where they have a patient coming 3 times and none organism was identified until the PCR detected Shiga toxin 1, where in our case, all Shiga toxin 1 are O26. We don't have any O157 Shiga toxin 1. In this case, 38% of all the Shiga toxin detected by PCR doesn't have any superficial antigen. But now, the next slide, we can compare the same result from the very gene, the detection of the gene, with the production of the toxin. And this is also interesting too. 9 of those 16 Shiga toxin that we detect by PCR doesn't produce any toxin. The Public Health Department was unable to identify or detect any toxin used in the method EIA. So all of them were confirmed by PCR, but the Public Health Department later agreed with the result that we got previously. But also I want to mention that from those 9 Shiga toxin that they weren't producing toxin, the 6 from the slide before, I will just go back to the first one. These 6 organisms that didn't have any superficial antigen are included in the 9 that didn't produce toxin. So we're talking about the 6 of those 16, or probably even 9 of those 16, if we were performing a stool culture, we're going to be having false negatives. Outbreaks. The other important information that we got was some outbreaks. Last year, during 2 weeks, we have 6 Campylobacter that were detected. During the first week, we have 4 of them. I called the Public Health Department and notified that what we got. They confirmed that they were investigating a possible outbreak of Campylobacter related to raw milk. The next day, we get the 5th one, and then the week after, we get the 6th detection. Also, we have an outbreak of norovirus between December and January from the last year and this year. 15 norovirus were detected during that period of time. And the importance of this test is we are able to only order just one target. Many of those patients come to the hospital and all the providers knew about the outbreak. So patients with clinical criteria to be included in the, if possible, one of the cases of the outbreak, the only norovirus were ordered. And many of those positive norovirus were only tested by only one target. So that also reduced the cost and also improve and make our decision to testing for patients smarter. Communication to providers is very important. And we need to communicate to them the advantage and limitation of the test. The advantage, we have to mention how sensitive the test, how fast is the test, what kind of organisms we are able to identify, and also make emphasis the difference between the Shiga toxin when the O157 or non-O157. And the limitation, we are not able to identify some Aeromonas or Plesiomonas, but also further culture identification is required to have the organism completely ID if Also, one of the limitations, if susceptibility is required, probably it will be delayed 1 or 2 days. Enough information on the report for result interpretation. I think this is key. Putting all the information the physician can read, even if it's a long page, is important for them. Most of them order this test routinely. So if they have that comment, they will get familiar with the test, and this is the idea of the report, information that we put in the report. I think it's very important to make interpretation for them for the Shiga toxin in a clinical way. We start reporting this test as a Shiga toxin positive, Shiga toxin negative. Many of them are calling back and say what that means. This is a 157 and not a 157. So now we report as a EHEC, Shiga toxin 1 or 2 detected. And also we make sure that we communicate with them and explain what a 0157, 0126, what that really means, and when the production of toxin also means. And they now feel comfortable reading Shiga toxin 1 or 2 from EHEC result to take decision. And basically, we just need to show them that it's a different perspective of the same problem. Make the lab requirements clear for specimen collection and transport. This is very important. We only receive fresh stool from a sterile container. We don't request a carry blade. We put the sample in. When we receive the fresh stool, we aliquot the sample to a carry blade. And that way we can unify the process. Giving the carry blade to patient and bringing the patient back to the lab, we found that we have some discrepancy between patient and the specimen. The quality of the specimen could be compromised. So this is the communication that we send. It's a really long comment, but every single detail of the test is there. Many of the physicians, they are already familiar with the comments, and they know what expect, and also from the test, and know the limitation of the test. We also have flyers. When the test came home and in-house here and the Marine General, we went to create some flyers for the physician. One of them was Enteric Pathogen PCR. So basically we explain what we do now, why we switch, but we explain very in detail what interpretation of Shiga toxin means. And this helped a lot to the physician to understand our result, and also make them understand the difference between 0157, 026, and other organisms. The other flyer was the comprehensive stool workup, and this is a work in progress when we try to reduce the amount of O1P that we receive. We used to receive 90 per month, now we went down to 70 per month. In that flyer, where we explain to them is how is our positive rates of bacterial and viral infection, and also we include information for the California Department of Public Health about prevalence and incidence of bacterial parasite infection. So in that way, we try to teach them how to order the test based on the most prevalent organism. One of the anecdotes I want to share with all of you is this is kind of off-label use of the test, but we use we have a positive E. coli for one of the blood culture, the gram-negative panel, in a patient. We report the E. coli, but when we reviewed previous results, we saw that this patient had a previous Shigella detected by the Enteric Pathogen panel the day before. So, and this is important, compare both panels, because the gene that used for detect Shigella of E. coli on the blood culture, the gram-negative panel, is completely different than the one in the Enteric panel. So we had the doubt, is this really an E. coli or is it Shigella? So what we did was off-label, communicating with the physician by phone. We told them that we suspect that that E. coli is really a Shigella. So we took the blood culture and put in the EP panel, and we detected Shigella. If this was a real E. coli, the panel would be negative, because the panel from the EP is created to ignore the E. coli that is present over there. The gene used for the Shigella is more specific for the genus. Common question that I normally heard about the PCR panel: how many samples must the lab accept, and when is acceptable to retest? We only accept one. We don't accept more than one. If the doctor wants to retest for one specific, for bacterial panel, for example, viral panel, we recommend to call to the lab and have a consultation with us before to proceed. And this is an example when we have a patient that multiple tests were performed, and the patient continued with diarrhea, was an outpatient. When the physician called back and asked that he wanted to retest patient because patient continued with symptoms, we recommend to perform C. diff testing, and patient was positive. So can this be performed stat? Yeah, this can be performed stat. We right now turnaround time is only 6 hours, could be even less. The test takes only 2 hours and 15 minutes on the instrument. The ED department, the emergency department, they are getting used to the test, and sometimes they call and say, "Can I have the test stat? I have a patient here that I want to send home." Sometimes the result get back and the patient is still in the ER. So I think the test can be performed stat if you have the personal and all the workflow in place. Should the target be separated by group? We separate them by group. I think it's a good idea, not offer the whole panel. But also, if you want to offer the whole panel, that's depend of what kind of organism and how do you feel that you should be setting them. But the flexibility of the test is you are able to separate those panels. So again, should bacterial, viral, and parasite target be performed all at once? I don't think that it should be, especially for parasite panel. I think they should be separate, and I hope that soon we can have a parasite PCR multiplex panel that can be performed in small hospitals like us. How to interpret Shiga toxin detection? So this is important. Not all Shiga toxin are 157 or Shiga toxin producing E. coli. I know that many of the publications, the CDC, this is the most prevalent. But what we saw here is only 4 of 16 Shiga toxin in the community around the hospital is real 0157. So most of them doesn't have any superficial antigen, and other ones, 6 of them are all 26. So this is important to understand how this organism could be reported, could be detected, and what the result means. So what to do with a positive result? We send the specimen directly to the public health department. We can have an agreement with them, but I think it's really important that we continue sending those specimen and organisms you are able to isolate to the public health department. That helps to create a database that also helps to evaluate and investigate outbreaks. So would it be necessary to continue with limited stool culture? That depends. We thought, or we consider that is not necessary for us. We don't have a problem with Pseudomonas. We don't have a problem with Plesiomonas. We keep in contact with physicians, a very close contact with them, so they are able to communicate with us and require any specific tests if they want to identify Pseudomonas or they want to identify some of the Plesiomonas, or also if they want to just evaluate the normal flora. That's why we don't do that. So we eliminate that completely. But that's depend of how comfortable you feel with the test, how is your validation process with the data from your facility. I think this slide is very interesting because it shows how we are working right now in the public health and microbiology department. Practically, we have everything changing every single day. We have new regulation, new requirements, and new tests. So practically, we don't have any time for us. Thank you very much. I just want to pass this.
Great. Thank you very much, Dr. Harrington and Dr. Alexander, for your insightful presentations today. I'd like to continue to invite our audience to send in any questions using that questions chat panel, and we'll start our Q&A session now. We have a few questions to start with. Our first question today: what has been the response of your ID docs and clinicians to molecular stool pathogen testing? And that question is for both speakers today.
Okay. Well, Dr. Harrington, you can start with the question.
I think the response from our side has been largely positive. I think when docs get used to having answers more quickly, they're in favor of it. And I think everyone is breathing a sigh of relief that we have rapid norovirus detection in our hospital.
Well, our IT doctor were very involved in the whole process to set up this test for all the organisms that we were showing them. I think there was confusion even between some IT doctors about how to interpret some of these results, especially for the Zika toxin 0157. That was the most common question that we got from physicians. In the beginning, we have a lot of questions. Physician was open to understand and learn from this test. But I think the key was communication, be able to go and talk to them in person and show them what kind of information we are getting for that new system and how they can use that information. I think that was very helpful. And now I think all of them like it a lot.
Great, thanks very much for those answers. I think we have time today for one more question. That question is for both our speakers again. Have you had any issues with reimbursement for this testing?
I'm not able to answer that question from my point of view, but I think that's something that we need to look at here now that we're 6 months post-implementation. So we haven't reviewed that, so that's pending.
In our case, I haven't received any kind of notification or comments about any problem with reimbursement of the test. I think that been very well integrated. Also, I've been trying to get some information about this because we only have a year and a half with this test, but during this time, we haven't got any problem at all with reimbursement.
Perfect. Well, thank you both very much for those answers. We've now reached the end of the question and answer portion of this webinar. If your question wasn't attended to during the Q&A session, the team from Nanosphere will do their best to follow up with you after the webinar. And if you have any further questions, please direct them to the email address that's showing on your screen. That's webinar@nanosphere.us. Thank you everyone for participating in today's conference. You'll be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen, and your participation is appreciated as it will help us to improve our webinars. Now please join us in thanking our speakers, Dr. Harrington and Dr. Alexander, by clicking this tweet that I've sent to all participants through the chat box. We hope you found this conference informative. Have a great day, everyone.